Okay. All right. So capnography. So capnography is the measurement of CO2 being exhaled, right? So it's end tidal CO2. So a patient has they produce CO2 in the lungs, and that's going to be exhaled, right? And we can pick that up on the monitor right here, right? A little side stream adapter here. We can pick it up on the monitor and get our end tidal CO2. Okay, so right here the patient produces CO2 in their lungs, they exhale it, and then we can pick it up right here and get our capnography. We can get a waveform, right? We get a waveform here. Oops, a little bit up like this. We can get a waveform, and we can get a number, right? So the idea is to be able to interpret the waveform, because IC is all about knowing what the waveforms look like, the different waveform changes, and what they mean. And then also we can figure out why it's low and why it's high. All right, so end tidal CO2, PETCO, where the pets go. All right, that's also, you can hear it called that sometimes, but it's a CO2 at the end tidal. So tidal volume, right? So that's with each tide of the breath, inhale, exhalation. So it's end of what? End of inspiration or end of expiration? Expiration, right? So it's at the very, very end of expiration, we get a value, right? That's going to be the most CO2 you're going to be exhaling, right? You exhale a little bit of CO2, and at the very, very end, you're going to exhale the most CO2, right? And this little IR sensor, like on our Zoll monitor, when you exhale CO2 here, right, it's going to pick up that CO2. And when you're inhaling, there is no CO2 being delivered by the ventilator, right? It's going to eliminate that waveform, right? The waveform is going to plummet down to nothing because it's only picking up CO2. When there's oxygen going across, there's no CO2 residual, right? And then when you exhale, the CO2 is going to be on the monitor, on the waveform, right? You're going to be able to pick up the CO2 being exhaled, right? And those numbers mean something, okay? So normal, it's nice that if you know a PaCO2, it's the same as end tidal CO2. It's 35 to 45. That's it, okay? So it's non-invasive, which is cool. It doesn't cause pain. You just attach it to your ventilator. You just have to know where to attach it and how to attach it, because there used to be like 5 different ways to get end tidal CO2, and nobody was doing it, unfortunately. So, but now we have, we have 2 really good ways. Our Zoll monitors can do it, and our bedside monitors can do it, right? So you just have a little module. It doesn't look like this. It has a little hole in it where you can put your little end tidal CO2 trap, and you can then measure your end tidal CO2 for certain patient populations that we'll talk about, right? End tidal CO2 lags behind, or is different than your venous CO, than your CO2 in your bloodstream by about 3 to 5 points, right? Normally, okay. So normally, if the CO2 that's being delivered to my alveolus, right, then it gets transferred across the alveolus, then it gets exhaled. That the difference between the alveolus and the blood is about 2 to 5 points, right? The beauty of it is that it always lags behind, right? It's never more than it, but it's always going to lag behind. It's like a little kid pulling a toy, right? So your toy is the end tidal CO2, right? But the actual CO2 drives it. Right? The actual PaCO2 will drive your end tidal CO2. Okay. If you're sicker, right, your alveolus is full of fluid, you have interstitial lung disease with fibrosis, you have a pulmonary hypertension, all those things are getting in the way of that alveolus. Therefore, you're going to have more than 5-point difference. So people was like, oh, my PaCO2 was, I don't know, was 55, and my end tidal CO2 was only 45. It's like, well, yeah, there's more difference because there is more stuff in the way. I'm trying to get the CO2 from the bloodstream to the lungs and exhale it, but there is stuff in the way, right? So it's not a reliable indicator to predict or to say what this PaCO2 is, but it will let you know about the trends of PaCO2. So yes, it showed you 45, but before and earlier than shift, it was 35. So it goes 35, 40, 45. That means the CO2 has been going up. What's the actual CO2? It could be 48, or it could be 52, it could be 62, but it does trend with it, right? And we know that tells us that maybe the vent settings need to be changed. Maybe we get an ABG to change the vent settings. Maybe the tidal volume arrestor rate is too low or high, do you think, on the ventilator if I'm getting my CO2 climbing up on the monitor?
Too low.
It's too low, right? So we have to get those changed. Okay, so under normal VQ, so VQ is what, if we have any good ventilation, good perfusion, we're going to have a difference of about less than 5, right? But impaired gas exchange, more difference. Impaired cardiac output is another important reason for end tidal CO2, right? We talked about the SpO2 being a poor man's A line. End tidal CO2 is also like a poor man's A line. You can't really get information about like the vasculature, but you get information about a drop in blood pressure immediately, right? Because not everybody has an A line that's vented, right? But everybody has an end-tidal CO2. They should, right? So everybody has an end-tidal CO2, so you can quickly see, oh, my end-tidal CO2 is dropping. That means my cardiac output is dropping. My blood pressure is dropping. I should go check it, not wait for the cuff to inflate another 15 minutes, right? So it's important that the cardiac output is being monitored at all times as well, okay? So we're going to see a lot more difference as the cardiac output is impaired, right? Because we deliver, if you imagine the blood just down here, we're delivering CO2 to the lungs, right? So that's bad color. CO2 is being delivered to the lungs, and if there's no CO2 being delivered to the lungs because my right ventricle is failing, all right, that's going to be less CO2 be delivered to the lungs, and less CO2 is going to be exhaled. Okay, but how this waveform works usually is you have CO2 in your alveoli, right? CO2 is all the way out here in the alveoli. It's sitting there at about 40, right? And then it's ready to pick up the 46 CO2 from the venous side. It's going to dump off the CO2, and we're then going to exhale it, right? And then, so the CO2 we expect to be about 35 to 45 as we exhale it. The other thing to note is that in the middle here, your CO2 is 0 in your bronchus and the bronchus and trachea. So it kind of explains the waveform. The reason why we bring it up is because some people have air trapping. And the reason why you don't have air trapping is that CO2 is left behind. So we can see a baseline. If this CO2 is building up, building up, and building up, the baseline is going up here. Baseline CO2 starts going up a little bit. That means they're retaining CO2. They're air trapping. So on the ventilator, it can be deadly. And we make sure we are catching that, and because it can start raising the pressure in the chest, dropping the blood pressure more, and causing more issues. Okay, so it's capnography is the measurement of CO2, and at the end of expiration, so they exhale completely.
Sorry, so then the waveform would be starting at like 10 or 20.
Yeah, it'll start going up. You'll see like it go 5, 10, 15. It'll start going up a little bit.
The baseline.
The baseline.
Gotcha.
Okay, so again, we have our end-tidal CO2 right here. It's just following behind the PaCO2. Okay, the PaCO2 is 60. The end-tidal CO2 might be 55. If the PaCO2 is 25, it's going to be on the other end. The kid went the other way, so the PaCO2 on the ABG is 25. The end-tidal CO2 might be 28. Right, just going the other direction. It's falling behind. Okay, so normal values 35 to 45. So again, that's nice. That checks a box somewhere. All right, so it's a difference about 2 to 5 points. But again, when we have lung pathology, then it's going to start getting more and more. But it's still reliable as a trend, right? So PaCO2 is always going to be higher, but we can always trend it, right? So what else? So in a metabolic acidosis, for instance, we're going to have a buildup of, we have this bicarb that's dropping, and we want to be breathing faster, right? We expect the PaCO2 to be 28, 30, right? We expect it to be below 35. But if that PaCO2 starts going to 35, 40, 45, when someone has metabolic acidosis, that's now called what? Mixed acidosis. So that's why it's important to have end-tidal CO2 also on your cardiac arrest patients, even during arrest, as we'll point out. During arrest, you can see if they're getting good CPR or not. You can see immediately if they got ROSC, and you can stop all compressions once you see that you got ROSC on the end-tidal CO2. Okay, so yeah, so that's a very common cause of cardiac arrest as well. When they intubate somebody who's breathing 36 breaths per minute, the DKA patient, and then, or let's say like a really bad pneumonia patient, they intubate them, the bicarb is like 12, they're severe sepsis, and then they set the rate on the ventilator to 16. All right, 16 is not going to compensate for that lung process, and is not compensate for the bicarb being so low. All right, so now you have a mixed acidosis on your hands. All right, so what determines end-tidal CO2? So we're back to our friend VQ, which we explained in detail last time. Right, so the ventilation is bad or the perfusion is bad. So it's good for both of them. And then for extra credit, you can say, oh yeah, there's this one thing where you can actually make more CO2. If you got a fever, if you have like hyperthyroidism, or I give a bicarb push, these things can independently raise my CO2. But most commonly, we're looking at V and Q, right? So they got a ventilation problem. So they have respiratory rate pneumonia, or sorry, respiratory rate. The respiratory rate is too low or too high, right? The respiratory rate is too low. What do you expect the end-tidal CO2 to be? It's going to start going higher and higher and higher. The respiratory rate is too high, you're going to expect the end-tidal CO2 to go down, down, down. It can tell you to change that might need to change the ventilator settings, right? And then pneumonia, ARDS, COPD, that's going to tell us there's a problem and if they're compensating or not. Okay, and then Q for perfusion. So what's the pulmonary perfusion? So what ventricle feeds the lungs?
Right.
the right ventricle pumps blood to the lungs, and that right ventricle has failed because of cardiac arrest, right? Or didn't get blood from the periphery because you have to have venous return up to your right ventricle, right? You have hypotension, you have a shock state, you have a right ventricle that's having an MI, or if your left ventricle has an MI, it's not pumping blood to the body, and it's not returning back to your right ventricle. So it can tell you that they're getting more and more hypotensive because of a cardiogenic shock or another kind of shock, right? So it's a way to track what the cardiac output is, right? Or if you straight up have a PE right there, right? Your right ventricle is pumping blood to this guy right here, you're going to see more dead space because the lungs are working fine, right? They're breathing the air in, air comes out, and then but there's no flow, right? If there's no CO2 being delivered, I'm going to have a drop in my end-tidal CO2 because it's not going to be exhaled, right? So that's the vascular portion. And then, of course, the ventilation portion. So I have a really bad, right here, it looks like a emphysema patient. They have a collapse of the distal airways right there, right? So they're unable to get air in effectively and also able to get air out effectively. So they have like a shunt problem happening here, VQ-wise, but they are going to also not be able to get the CO2 out as effectively. The CO2 starts trapping behind, or not trapping so much, but starts building up, building up, building up. That's not going to, you're going to see a rise in your end-tidal CO2. Okay, when you throw one of these guys on a CO2 retainer as a COPD, you're going to see higher end-tidal CO2. You have to adjust your alarms. And you say, okay, right now their end-tidal is 52. I'm going to track that and see if that correlates to ABG and they're compensated. I know 52 is kind of where they should be sitting. Okay. All right, can end-tidal CO2 predict your PA CO2? No, because it's about 3 to 5 points normal, and it's up to like 10, 15 points based on their lung process. You can't say they have this percentage lung process, and therefore there's no formula to figure that out. But you do know that it trends with it. Okay, so why even use it if you can't predict an actual number? Again, the cardiac output situation, you can trend in real time. Your patient needs to get CPR. Right, usually if your end-tidal CO2 is less than 20, that means you're not delivering CO2 to the heart and it's not being exhaled. So you're going to have a end-tidal CO2 that's going to start going down and down and down, right? So like a patient right there that arrested, we would have the end-tidal CO2 place. We say, oh, it's 22, it's 18, it's 16, and you're going to feel for a pulse, right? Instead of just waiting for something else to happen, right? If they have an arterial line, you can, that's great. You have a lot more tools to assess if someone's getting perfusion. But sometimes you don't always get an arterial line, right? So you always can get an end-tidal CO2 on a vented patient. Okay, if it's too low, that's what we're talking about. It's like less than 20, it's cardiac output no matter what, right? It's not going to be less than 20 because of a breathing situation. It's less than 20 usually when there's a cardiac output situation. The blood pressure is going down, the heart's failing. Those are situations where we have a end-tidal CO2 less than 20. If it's like 25, 28, that's someone that's breathing fast or slow.
I'm sorry, what was it?
If the end-tidal CO2 is like 25 to 28, are they breathing fast or slow?
End-tidal, they're breathing too fast.
Breathing too fast, but it might be appropriate because they might have a metabolic acidosis, right? So they might have a raging UTI and the bicarb's 12, and you want their end-tidal CO2 to be 28, right? You don't want that, during your shift on your next assessment to be like 36, and then it's 42, right? So you have that trend, right? There's no reason for that to jump up like that, except for some fringe cases like a bicarb push, and we'll talk about why. Okay, if it's too high, right, CO2 starts going, end-tidal CO2 goes to 46, 52, 62, then that's a buildup of PaCO2 because again, it's pulling it with it. Okay, so PaCO2 and end-tidal CO2, there is a difference there, and they are trendable. All right, they can't predict which one's which. You can predict that my end-tidal CO2 is 62, I probably have a high PaCO2, but you can't say it's exactly this. Okay, so can I trust it if there's some false positives and false negatives? Yes, you can. You just have to think about a few times where you might get false positives and false negatives. So esophageal intubations. Sometimes when you do an esophageal intubation, you'll get a CO2 reading, right? You have the little capnostats here, those capno checks. They're purple. It's just literal litmus paper you can buy on Amazon, right? They're purple, and when CO2 hits the paper, the litmus paper turns acidic, right? It turns yellow. So that can happen, right? This litmus paper you can buy on Amazon, that turns yellow, and you have an acid present. But there's hydrochloric acid in the stomach, right? So if you have an esophageal intubation and they're vomiting, that can make it be a false positive, right? So the capno check is a good way to just check it, but it's not the most accurate way. The most accurate way is to hook up the end-tidal CO2 to the monitor so you can see a waveform. So you see a number of like 36 on my end-tidal CO2, but if it starts going down after 6 to 8 breaths, see the trend going down, that is definitely an esophageal intubation. So we have a 100% check that that is not in the right place, right? So it's a way, yes, there's a false positive with esophageal intubation, but once you hook it up to the monitor, you know exactly it's in the right place or not. Okay, so esophageal intubation is going to be it's going to be flattened right away. Okay, why would it be higher initially? If they're vomiting, aspirate. If they drank Diet Coke, right, that has carbonated acid in it, right, carbonic acid in it. If they got nitric oxide, which you don't really do in the ICU, but maybe in an anesthesia setting. Again, nitric oxide is acidic, so that could cause a change in the litmus paper. Or they have what else? They got intubated during the code, and we gave some medications during the code. Like epinephrine is very acidic, right? So you intubated them, and well, that wouldn't be esophageal, but anyways, it would be that can be another reason why you might get a falsely high initially. Okay, false negatives, right? Why would you have increased differences, right? Like, well, I put it in quotes because it's not really false negative. We expect it to be a bigger difference in situations where we have low cardiac output or low VQs, right? Right, and yeah, high VQ would be a low cardiac output, right? So when you have that difference there, that would be we expect that. Is it really a false negative? No, because we're not going to be able to accurately estimate it. We just want to be able to trend it, right? So here's like a normal end-tidal CO2, and here's a low VQ where I have a lung process going on, and that's going to make my end-tidal CO2 go either up or down. It depends on how they're breathing, right? If they're breathing really fast because of that lung process, we're going to expect them to have what kind of end-tidal CO2 if they're breathing fast.
Depends on the lung process, but...
Well, if the lung process is making them breathe fast, well, what do you expect the end-tidal CO2 to do?
Oh, they will go down.
Yeah, end-tidal CO2 you expect to go down, right? And if it starts going up and up and up with the lung process, that means they might be tiring out, right? They might need some more support. Okay, it's like, well, if they're not intubated, how do I know they're not tiring out or they're tiring out? Well, you can look at them, or you can look at if they're on BiPAP therapy, you can look to see what the tidal volume is on the BiPAP. It'll tell you right there. We also have these cannulas here, right? If they're not on oxygen, right, they use this little small one, the clear one. But if they are on oxygen, you can use the green one, right? And it has a little sampling port. It's split in half, and it can measure their end-tidal CO2. Okay, and then you have issues like mouth breathers and such, but that's a way to measure their end-tidal CO2. Okay, there may be more disparity, but it's the trend that matters. All right, same thing when you have a high VQ. When you have a PE of some sort, that's going to be a lack of flow to the lungs and a lack of end-tidal CO2 being exhaled. So that's a way we can trend it and see if it's all of a sudden, that's A, maybe it's disconnected, or B, if it's accurate, then we know that there could be a lung process or a vascular process happening.
Will CPAP seal over this?
What's that?
CPAP will seal over this?
No, CPAP is a little bit wonky. It's not like a BiPAP machine over the end-tidal CO2 cannula. It's not as accurate. There's not a great way to sample off those guys. Okay, so yeah, so we got normal CAPNO waveform. So you know what a normal one looks like, and then we'll talk about abnormals, right? So first you got to start somewhere. Like the chicken versus the egg. So we got to start at phase 0. All right, so we're going to start and end with it. So phase 0 is your inspiration. That's your return to baseline. So over here in yellow is your phase 0 on the bottom there, right? So it's your inhalation. Do you inhale CO2? No, not unless you're on a simple mask less than 6 liters per minute. Yes, you might be. But if you are, if you're normally, you inhale just straight up oxygen, right? Or straight up room air, which does not have CO2 that's detectable, right? Because room air has 0.03% CO2, so you're not going to be able to get a lot of there. So it's going to be at baseline here, right? So we were up here and we're plummeting down, right? That is phase 0, right? It's the air coming into our lungs, and it's going to cause our waveform to drop to 0. All right, so that's phase 0. It overlaps with phase 1 a little bit because phase 1 starts halfway there, right? So right there, phase A or phase 1 right there, right over here. That's we're blowing out all the air that's in our bronchus and trachea. Remember that air has no CO2 in it, right? So that has to leave first. And then you're going to see the CO2 to start to climb up dramatically because CO2 is right behind it, right from the alveolus, right? All the CO2 out here is ready to come in. First, it displaces the air right here, right? And that has no CO2, but there is CO2 out in the periphery. And all that CO2 is going to be exhaled, and it's going to be a dramatic rise. See how the slope is very, very dramatic? It's almost upright, right? Like half dome. All right, so it's all the way right up, okay? And that's our phase one. That's the exhalation of the dead space, all that CO2 in the dead space. And then we have some extra CO2 that's going to be, come right behind it all the way at the very, very periphery, and that's going to be all the stuff from the alveolus, right? So all that alveolar CO2 is going to be exhaled after that, right? So the CO2, so it's going to exhale completely, and then it's going to slowly come up to a peak, okay? And once you start inhaling, now that goes away, right? That's now your phase 0 again. So what can happen? What are some things you can see? Well, what if they have a difficulty getting air out of their lungs, right? Who has difficulty getting air out of their lungs? Yeah, an emphysema patient and a asthma patient, they're bronchospasm, they have difficulty getting air out of their lungs. So you're going to see this slope. Notice the slope is much less here. All right, so the slope is like this, looks like a shark fin. All right, the shark fin appearance is a sign of bronchospasm. So that's another benefit of having end-tidal CO2. It's like, my patient needs a breathing treatment. How do you know? Look, they're having bronchospasm, okay? And they could be like anxious and squirming on the ventilator. Like, what's wrong? You're fine. You're in the ICU. It's Friday, right? You're good, all right? But then you realize the end-tidal CO2 has, oh, let me get your breathing treatment, right? So because they have a shark fin appearance, okay? Because they have difficulty getting that air out of the lungs there. Instead of it being nice and upright, it's starting to trend down, okay? And then we have like we mentioned with asthma patients, COPD patients, they can trap air, right? So this is this air trapping I was talking about before. So the trend on the baseline can go up. So phase 0 comes all the way down to baseline. But if phase 0 does not come to baseline, that could be a trapping of air, okay? So that's a time where you would then say, well, let's see what other strategy we can do, which we'll talk about in the next lecture about how to fix like auto peeping and how to fix a patient that is trapping air in their lungs. That's on the ventilator at least. Okay.
So we want to see a slightly flat top.
On the bottom, you want it flat. On the top, you want to see a little plateau. You want to see a plateau that's kind of upright a little bit. Okay. The little analogy is if that was a top hat, you want a teacup to sit on top because you are fancy. Okay. All right, so the waveform again. So again, it needs to be like a little alveolar part of the curve where we blew out the CO2 really fast, and then now we're going to blow out until we inhale. Okay, so that's our different phases of the cycle, and we can see changes in the baseline. If you change the baseline, this baseline is going up over here. Like over here, our baseline is going up a little bit, I believe, right here, right? See the baseline going up like that? That is air trapping. The CO2 is not getting out completely. There's different reasons for that. We'll talk about those when we talk about the vents. And then the height of it. So if this height goes from, instead of being 35, let's say, 35 to 45, but it starts going up, well, that's why would the end-tidal CO2 go up? Why would your end-tidal CO2 go up? You've got decreased respiration tidal volume. But there are other little fringe cases you can think of the back of your mind. If they got malignant hyperthermia, they got fever, hyperthyroid, that's cranking up the CO2 production, right? Where do you make CO2? Every cell makes CO2, right? It's part of cell respiration, right? The O2 gets delivered and the CO2 gets exported out of your cells, right? Out of your mitochondria and such. So if that's rapid situation, you're going to see your end-tidal CO2 be higher, right? And the frequency. So we can see the end-tidal CO2 is really fast over here, right? So hypoventilation, you can see that how it's going up and up and up, or you can see your end-tidal CO2 waveform being more frequent. You can get a respiratory rate off this as well. It's your best respiratory rate, right? We have the EKG patches, which kind of uses impedance thresholds and can maybe get you an a respiratory rate, but end-tidal CO2 on the monitor will get you it every time. Okay, because it knows here's exhalation, there's inhalation, there's exhalation, and it can say, well, that's your respiratory rate. Okay, and then rhythm. So you can see if they have, it should be nice. There shouldn't be any break in this rhythm here. It should be nice and up and over and down. But sometimes you have a little dip right here. That's usually on a patient that might be on neuromuscular blockade, in quotes, because someone not checking the train of 4, and the patient's breathing on top of their respiratory rate. Okay, and then also there's the shape can like collapse a little bit. So instead of going up, it can collapse a little bit. Usually happens in emphysematous patients because their airways collapse at the very end of their cycle. And then obstructive pattern we mentioned. What kind of fin is it?
Shark.
It's a shark fin appearance when they have a obstructive pattern. Okay, because instead of being really, really rapid, it's going to be hard to get that air out of the lungs. All right, what equipment do you need to measure end-tidal CO2? So you can just do a check, like the CAPNO check, right? This guy right here, right? Someone wants to nominate who's going to breathe into it, but first of all, let everybody see it first. Don't just breathe into it and pass it. Don't lick it and pass it, please. All right, so you can open it up. So that's the CAPNO check, all right? So inside of it is just litmus paper from Amazon, right? And it goes from purple to yellow, right? So an acid turn yellow when there is acid present, right? And a CO2 in acid, yes, it's carbonic acid, right? So how do you know that it's supposed to be gold? Because gold is good. You could think of that, right? Gold, right? So that is what you want to see, right? So is there end-tidal CO2? That's all this says. Is there CO2 present? But there could also be vomit present, right? There could also be epinephrine from an endotracheal endotracheal administration of medications. That could be also why if that happens. But it's like, what is the end-tidal CO2? What is the trend? That's where we actually get a waveform on the monitor, right? We get our end-tidal CO2 waveform. That's what we want to see, right? Because esophageal intubation, it could turn yellow if they had a recent Diet Coke, right? That could be the reason, or a lot of aspirates. So we want to make sure we have a waveform that doesn't just start plummeting and because of a lack of exhaled CO2. After 6 to 8 breaths, usually the Diet Coke goes away, right? So that's why you want to have a waveform capnography. So we have 2 ways to measure it. We have our what's called infrared way, and there's a side stream sampling. So infrared is where the IR, just like our SpO2 sensors, it just measures the interruption of oxygen. The O2 will absorb some of the infrared waves and not hit the other side of the sensor. So then it can say, oh, this is what your oxygen level, this is what your end-tidal CO2 is. Okay, so it measures the end-tidal CO2. Our Zoll defibrillator does that. So after class, we can go and show you on the Zoll how to set that up. All right, every code needs to have that set up because it's important in codes to measure end-tidal CO2. So it measures how good your CPR is, and it measures if you have ROSC. Has a lot of good information. Okay, so every Zoll defibrillator has it there. So this is kind of what it looks like right here on our Zoll. It uses IR spectroscopy. So you have to warm it up because it needs to be. Otherwise, if you don't warm it up and you just let it warm up, naturally while it's still attached, it's going to start condensating. That's how condensation works, right? It goes to warm and cold environments. So you want to make sure it warms up. It takes like 90 seconds to warm up. So if you have a provider yelling at you, it's like 90 seconds, cool it, dude. It's okay, right? I'll get you your end-tidal CO2 shortly at the next pulse check at least, right? So it takes a second to warm up. Otherwise, the side stream one doesn't take any chance to warm up. There is a delay because it has to, be exhaled. The CO2 has to come out. It has to then take a little detour over here, take a little sample. Yeah, CO2 is 35, right? So it's going to take a sample. So there is a little tiny delay, but not as much a delay as firing at the Zoll. Otherwise, once the Zoll is fired up, the defibrillator is fired up, it'll read it instantaneously. Okay, so that's how we measure our end-tidal CO2. We could capture an exact number with our monitor, but if you notice on their CAPNO check here, it's divided in like 3 different sections, right? Yep. So it tells you. So it approximates how much CO2 there is. So it tells you if you're this section here, you're about 5 to 8. You're this section over here, you're about 30 to 35. And your section here, you're about 20 to 25 CO2. So it can approximate your CO2 as well. Okay. So equipment we have. So we have our bedside GE monitor. Can do it, right? All you got to do is plug in this little module right here. Right. So the module's right here. I'm going to pass this guy along. Right, and then you have to get a water trap. You want to pass this guy along. Right now, that's just a dummy module, so imagine a little hole for it to go into. And then you have your wire here. Sorry, this guy. I passed it around earlier. This wasn't the cannula. All right, that's the sampling tubing. Okay, and then you got the little adapter for the ET tube that we can hook it into. So you need those 3 things, right? The little white adapter, right here. This little white adapter. Sometimes what we can use is we can hook it up to what's called the HME, which is a piece of our ventilator circuit. So we can just hook it up right there. Okay. So yeah, you need a sampling line, the water trap, and the ET tube adapter, and that's like, sometimes all you have to do is hook it up right to the HME. Okay. So the Zoll defibrillator, you have to what? You have to warm it up before you attach to it. Okay. And it should be in place for patients who arrests, right? If the arrest is more than 2 minutes, you really should have the end-tidal CO2 fired up. If it's less than 2 minutes, you can say, well, it took time, right? So water trap, the little water trap right there, they come in 2 flavors, green and silver. The silver lasts like 3 months. The green lasts like 72 hours. It's like, well, my patient fills it up in 1 day, 1 shift. So you can just pop it open. You pop it open and empty it out. So you can pop open the packages. Right, you can try that. You can pop the package open and try to take the little gray cap off. Right, you can see how it works. It's just like when you meet some band nerds and you got some trombonists and trumpet players, and they empty up their little trap at the end. It's like it's not saliva, it's just condensation, right? It is condensation with their kisses. All right. So yeah. So water trap can be emptied. You do want to empty it when it starts filling up. Okay. The Zoll, really, there's no filter on it, but sometimes you do have to change it because it's not meant for like continuous monitoring. Okay. An end-tidal CO2 sampling port, that's the one I pass around the cannula here. That's where you can take a little sample. It's split in half. So one half gives oxygen, the other half measures the end-tidal CO2 being exhaled. Okay. So for the Zoll again, so in orange here, the wire should be it's zip tied in there because people somehow they disconnect it, right? And the wire itself costs $2,000. Right, that they're in the wrong business. You thought an HDMI cable at Best Buy was too much, right? Why are you charging $80 for an HDMI cable? I can buy it on Amazon for $8, right? So this Zoll cable is $2,000. So please don't disconnect it from the Zoll itself. So my Zoll doesn't have one, just take another Zoll that does have one. Okay, so you have that cable needs to be attached, right? And then our crash cart checks, we make sure this is there for for any kind of situation like today, right? And then we get it fired up. Then you have to zero it, right? You have to zero our little adapter there before you hook it up to the patient. So the Zoll has the wire and the Zoll itself, and then you get one of these guys. This is on the crash cart itself, in a little bag, and you attach that to the little adapter there, the cable, and hit 0 on the Zoll, and then it'll say ready to go. And then you hook it up. If you try to zero attach the patient, it's like weighing a patient, like zeroing a patient with the patient in the bed, right? So you don't want to do that. You want to fire it up, attach your adapter, zero it, and then you can attach it. Okay, so where does it connect to, right? The mainstream one, right? You just put it inside the circuit there, right? You want as close to the patient as possible. So here's the ET2 coming out, and here's the vent over here. You want your end-tidal CO2 as close to the patient as possible. That's the goal, right? So this end-tidal CO2, I would probably put it over here. That'd probably be a better place to put it, but it'll still capture it. It'll give you good values. Okay, so this one right here, this is a side stream, right? So as the patient exhales CO2, it goes, some of it goes and we exhaled, but we also measure a little bit on the side, right? It's just yummy in my tummy. All right, there's a little time delay. In pediatrics, they can't really use it because the volume of the kids are not as big as our side stream adapters. So they do have to use the IR ones. Okay, and again, it takes about 90 seconds to heat up on the Zoll defibrillator.